Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hello and welcome back to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, and we are in our holiday Q&A series. This means for the next few weeks, I am doing a series of Q&A episodes from the voicemails that you call and leave. Today's episode is all about trying to get pregnant. So all of your basic TTC, trying to conceive questions, whether you're just beginning or you're having difficulty. I always love these Q&A episodes because they really tell me what you guys are curious about or struggling with, and gives me a lot of insight into gaps in knowledge and general questions. And nobody asks your question as well as you do. So if you have questions, feel free to call and ask them. The voicemail is 657-229-3672. Again, the voicemail 657-229-3672. You can also ask questions on Instagram at Monday at nataliecrawfordmd. We will answer the questions there and in the weekly newsletter. The newsletter, nataliecrawfordmd.com/newsletter. You'll find recipes, updates, my favorite things, and some of your fertility questions answered right there. So we're going to go ahead and dive in to this episode all about TTC Q&A.
Hi, Natalie. My question is about basal body temperature and temp tracking. I was curious if you do a frozen embryo transfer and you do have success and get pregnant and you continue tracking your basal body temperature, if you have a large decrease in your basal body temperature, does that mean anything? Because I know if you get pregnant without IVF, it could mean a miscarriage because of that drop in progesterone. But if you're supplementing with progesterone and oil or progesterone suppositories as well as the progesterone and oil, does that drop in basal body temperature mean anything? And should you just stop tracking at all after you do have success and get pregnant with your basal body temperature to decrease any anxiety? Thank you so much. Appreciate all of that you do for us.
Basal body temperature is a method of cycle tracking where you're trying to determine if you did in fact ovulate. There's a few different methods of what we call fertility awareness methods, and these are all ways where you can become more aware of your cycle, and I'm very passionate about this. In general, when you're doing basal body temperature, what you are looking for is the rise in progesterone causing a rise in your temperature increase. So really quickly, you have a follicle inside your ovary. The brain sends out FSH, or follicle stimulating hormone. FSH stimulates a follicle to grow. As that follicle grows, the egg matures and makes estrogen. As that estrogen gets high enough, it communicates back to the brain, and then the brain will send out one big surge of LH. This LH surge is what is going to tell your body to rupture that follicle, let the egg come out, and then it will reheal. If you're tracking with ovulation predictor kits, you will notice that these are an LH urinary monitor. So you're trying to do one every single day and detect the day where your LH is first rising. So I recommend you check OPKs between 10 a.m. to 2 p.m. The day you get the positive is the day before you ovulate. And if you're trying to get pregnant, you target intercourse on those 2 days. If you are tracking with cervical mucus, the cervical mucus is due to the high estrogen levels. And so as that estrogen gets to the peak level before it signals that LH surge, you're going to have this very sticky egg white cervical mucus, especially right when you wipe right before you go to the bathroom. That is considered your peak fertility day with cervical mucus, and recommend intercourse that day. Well, after the follicle has ruptured, allowing the egg out, the follicle reforms. And now it becomes a cyst known as a corpus luteum that makes progesterone. And what's so interesting is that the brain is triggering the cyst to make progesterone in pulses right from the brain. So these LH pulses are coming from the brain up and down. The corpus luteum is making progesterone in response to this. So your progesterone does rise and fall throughout the entire day, and studies have confirmed this. Having a progesterone level higher than 3 nanograms is confirming that you did in fact ovulate. You don't make progesterone outside of ovulation. Well, what's really interesting, progesterone does so many things to your body and it increases your body temperature. So you get this rise of your core body temperature once this progesterone is starting to be made. So if you're tracking your temperature, what you're doing is taking your first morning temperature every morning before you get out of bed, before you drink water. And of course, there's a lot of new wearables that might make this a little bit easier, but traditional BBT every morning, tracking your temperature. What you're looking for is when it rises, usually a half to a full degree. And once it rises, you now have confirmation that ovulation did in fact occur, typically a couple days ago. If you look back and you chart for a while, you can usually see often people will have a little bit of a drop in their temp right around that follicle rupture, and then a rise once that corpus luteum reheals. That's just due to disruption of the cells that make other hormones. That's the same reason why people might get some spotting around ovulation, because when the follicle ruptures, the cells that make estrogen are destroyed a little bit. Estrogen levels can drop, and then they rise again once the corpus luteum is made. Okay, to answer the question, tracking BBT can be a really great way to see if you did in fact ovulate when you think you did, and if your cycle is accurate, if your luteal phase is good. However, when you're doing artificial cycles, when it's frozen embryo transfer and we are giving you progesterone, BBT is no longer effective. Honestly, when you check your BBT is a lot going to depend on when you gave your progesterone shot. Some clinics do it in the morning, some do it in the evening. If you give your shots every morning and you're taking your temperature, I'm going to bet that some mornings you might have less in your system. Levels are going to start to drop before you get that next shot. I don't worry about that on the whole because levels do drop up and down the whole time. Also, so many other things can influence BBT, but being on artificial hormones definitely does. I would never give up on a pregnancy or stop my progesterone because I didn't get a temperature rise or because I had a temp drop. In a natural cycle, once that HCG from the pregnancy is implanting, that's going to now stimulate a constant and increasing amount of signal to that corpus luteum to really churn out some progesterone. And so you often will see a persistent or a continued elevation state. But the amount that we're giving you in PIO is so much more than you're going to be seeing in pregnancy. So honestly, my recommendation in this case is that you just do not check BBT. The only utility of BBT is to tell us that you ovulated. We don't care about that because we started progesterone, we're artificially doing it. And if I wanted to track for early pregnancy, I would get some really early pregnancy HCG tests and just start testing those.
Hi, Natalie. Thank you so much for doing this podcast and doing all your videos and providing us with so much information. I really appreciate it, and you've helped us so much. My question is, I work overnights, and I also work day shifts. I'm a nurse, and I've been doing this for almost 5 years, and I've been trying to conceive. And my question is, could that impact my trying to conceive journey? I've been working at this place for a very long time, and I don't plan on leaving, but I'm also trying to conceive, and I don't know if this could be impacting it. Thank you so much.
This is a really great and interesting question. So when you're working the night shift, you are often switching back from days to nights, even if you work a series of nights, and ultimately getting less sleep than the average person, even when you do sleep, and it's ultimately more stressful for your body. However, people have to work night shift. It is part of the job, part of certain jobs. I have definitely had times in my life where I have done that. There have been studies showing, number one, yes, people who work the night shift are more likely to have infertility and need fertility treatments than women who do not. And that is actually across all ages. We've also seen just longer time to pregnancy, period irregularity, a higher rate of endometriosis. And so when you start thinking about the reason why, a lot of it all comes back to a stress inflammatory state. So if we think about the fact that you're not getting enough sleep, sleep is when your body heals itself. That is when you're able to decrease some of your inflammation naturally. And it also resets your hormones, for lack of a better word. When you're not sleeping, your body is going to be functioning in a little bit of a deficit. You're going to go into the day not having some of your inflammation healed. When you are tired, your cortisol, stress hormone is up, and that itself is inflammatory. And your brain cannot function with this chronic inflammation without there often being consequences when it comes to your hormones or your periods or your fertility. In addition to just the stress of not getting enough sleep and healing, melatonin, which is an important part of the falling asleep process, is important in the anti-inflammatory pathway. It's an antioxidant, but it also contributes and interacts with our gonadotropins, so LH and FSH from the brain, and specifically that LH surge. So people who are not having as much melatonin may not have as strong of an LH signal or may have an irregularity to their LH surge, and that might make it harder for them to ovulate. That might make it harder for them to get pregnant or make it take longer. And ultimately, I view that as a level of hypothalamic dysfunction. Not that true hypothalamic amenorrhea. The brain is releasing some hormones, but it's not sending out an appropriate amount of LH to the situation because it doesn't have that melatonin interaction that it should. So it's missing a piece of the communication system. Okay, well, what are you going to do about it? First of all, do I think everybody who works night shifts has to quit their job if they're trying to get pregnant? Absolutely not. I do think it's important to look inside and see if you are potentially having any other symptoms of chronic inflammation or signs that your body is not functioning at its ideal state. So this might be things like fatigue, GI disturbance, gaining weight, irritable mood, depression, anxiety, and there's a whole list of chronic inflammatory symptoms. If you are feeling some of these and you don't have another medical diagnosis, I would consider going to my boss and seeing if for a period of time you can switch over to days. At the end of the day, if your body is being constantly stressed by your work environment, no matter how much you love the job, your job is not worth your health. And I mean that with my full heart. You are expendable to your job. I have learned that. Many of us have learned that. And it is not worth compromising your health for it. So advocate for yourself and pay attention. Of course, people who work shift work can get pregnant. So this is not everybody's going to have infertility. But if you personally are struggling and if you're having symptoms of inflammation, you're understanding that your body is not functioning in its optimal state. If that is your body's response to shift work, can you change it? Can you work more together? Can you change the shift hours? Can you do it more infrequently, or can you temporarily switch? And I think these are really important conversations to have with yourself and your employer. All right, so if you have a question, please do not hesitate to call 657-229-3672.
Hi, Dr. Crawford. I am 29 years old, soon to be 30. I was taking hormonal birth control pills for 9 years until I stopped about 5 months ago. At my preconception appointment before stopping birth control, my doctor said that it could take up to 3 months for my cycles to get back to normal. But since stopping, I have had 5 normally timed cycles, all resulting in negative pregnancy tests and then getting my period. I've been tracking my LH and basal body temperature each time, and both have been very, very consistent like clockwork. I'm concerned because my periods are always really light, where most of the time it's more like brown spotting than an actual period. So my question is, when should I be talking to my doctor about this? And is there any sort of pre-screening that I could ask for or should be asking for to make sure that everything's okay with me and also my husband? My biggest worry is that we'll waste time trying on our own before finding some problem down the road, as infertility is a problem for several women in my family. Thank you for taking the time to answer my question, and I am looking forward to listening for a response. Thank you. Bye.
This question has a few different pieces to it, so let's break it down. Number 1, anybody can have screening or testing of your fertility if you wanted it. You just need to ask for it. What does that mean? Number 1, it doesn't mean that I can prove you're going to be fertile or you can get pregnant. But can I see if there are problems that we can identify that are going to cause issues, regardless of if you've been trying, if you have light periods, any of the above. That testing can include, but does not always, testing your ovarian reserve, so how many eggs do you have, ultrasound or an AMH blood test. Easiest for an OBGYN to just order an AMH blood test. You can have a semen analysis. Male factor contributes in almost half of all cases in some way. A third of cases completely due to sperm factors. And then you can have an HSG or a test of the inside of the uterus and the fallopian tubes. Those are the basic things that in somebody who's ovulating are going to hit the top things that are other problems. Now, any of those things being wrong doesn't mean you can't get pregnant, but it does try to help stratify risk. When it comes to trying to conceive, over 70% of people are going to be pregnant those first 6 months. So infertility is not the most common outcome, but the way that I think about it is that for people who are younger, under age 35, most are going to get pregnant those first 6 months. So when they don't, will another group get pregnant in the next 6? Yes. Is it significantly less people? Also, yes. I do not believe in forcing you to prove something's wrong before we will do basic testing. You should not feel held to that. Do you have to get basic testing if it has only been 6 months? Also, no. So remember that screening is all about when does the cost of the test justified by the prevalence or the probability of finding somebody with the problem. That doesn't mean anything to you as an independent human, because if you have a problem, you want to know ASAP. If you have risk factors for a problem, if your periods are irregular, shorter, if you have severe pain with your periods, history of gonorrhea, chlamydia, endometriosis, been told you have PCOS, pain with intercourse, difficulty for your partner for erection, ejaculation, they're on testosterone, or any concern there could be some male factor, maybe undescended testes as a child, do not pass go. Just go get checked out so that you can be the one to make that choice if you want to accelerate or advance into fertility treatment sooner. I 1000% agree with what your doctor said. The birth control pill is a type of estrogen and progestin that are communicating to the brain to prevent you from ovulating. So you're not making natural estrogen or progesterone. In addition, that progestin is also preventing the uterine lining from growing quite as thick. That can lead to some of the very ideal side effects of the pill that people do like, meaning light periods, no periods, very painless periods, as compared to what people may have naturally. And everybody's different. When you stop the pill, however, we need your body to start ovulating again. And this may take longer depending on what is going on underneath your system. And the reason why we say 3 months is not because it takes the pill 3 months to get out of your body. The half-life of the pill is very fast. That's why if you miss one single pill, you can get pregnant. But because it takes a while to see an ovulatory pattern, and people's cycles can be very normal and be, every 5 weeks. So how are we going to know if you have an abnormal period if we haven't given you 2 or 3 months to have one? When you stop taking the pill, we're asking the brain to turn on and send out FSH. Some people do have underlying hypothalamic dysfunction. Their brain's not going to turn on. And that's going to present itself without having a period. Some people are going to have underlying PCOS and their brain is sending out hormones fine, but it's not a strong enough signal to their ovaries. And that's going to present itself with irregular or absent periods. One of the things that's a unique problem that we worry about sometimes with the pill is that depending on how long you used it and the way that you took it, did we thin out the uterine lining to a significant degree from a very prolonged progesterone exposure? This is typically much more common in a situation where you were taking the birth control pill continuously every single day, never having a period, which is fine. You don't have to have a period if you're on hormones like that, or if you had an IUD or some very intense progesterone exposure. That means that everybody's different, and depending on how long you've taken it and how you were taking it, it could just be that the lining hasn't gotten that opportunity to fluff up. In general, if you are getting a regular bleed, it also just may be this is your bleeding pattern. Reasons when I'm much more concerned about this is if you had a very different cycle before you started the pill, really, really heavy bleeding, if you've ever had any instrumentation of your uterus. So maybe you did have an IUD before you started the pill. Maybe you had a miscarriage at some point, had a DNC. Maybe you had a pregnancy termination. Any case where there is instruments that go inside the uterus, I am now concerned that potentially there's scar tissue. Regular periods that are very light and distinctly are a change from before are concerning that the lining of the uterus, the endometrium, is not responding appropriately, or it can't respond appropriately, maybe because part of it is damaged. That is sometimes diagnosed with that X-ray dye test, the HSG, or a very specific type of ultrasound called a saline sonogram. You should always tell your doctor if you're having a change from before. Hey, it's been 6 months. My periods used to be clotty heavy, took the pill for this long. Now I have this very light, scant blood, don't even need a pad, period. I'm concerned something could be going on. Please, your doctor is not magic and they do not know what's happening unless you tell them. And if you've always had light periods, way less concerned than if this is a new finding. Last thing about this is sometimes the versions of hypothalamic dysfunction. So you're ovulating, but maybe you're not growing quite as good of a follicle, making as much estrogen. I would typically see that with some type of ovulatory issue, a short luteal phase or closer together cycles, or ovulating faster. So your cycles are maybe closer together, but you have low ovarian reserve. So you're growing that egg faster. That can also cause a thinner lining because by the time you ovulated, that egg grew so fast in response to that strong signal from the brain that we see as you're starting to run out of eggs. So ovarian reserve testing to me is also a part of this just to make sure we have the full puzzle.
Hi, Dr. Crawford. Thanks so much for your podcast. I have a question regarding my cycle length. It usually ranges from 45 to 48 days. I've been tracking my fertility at home with at-home testing, and it does seem I'm ovulating around day 33 due to increased progesterone afterwards. Should I be concerned about this cycle length, or is that abnormal within the monthly period length? It does seem my luteal phase is regular because it lasts around 14 days. I usually ovulate as per hormone testing at home. It seems like day 33, but my follicular phase is really long. The luteal phase, though, is like 13, 14 days. I don't know if I should be concerned. Thank you so much.
This is such a good example of something we know to be true, which is the luteal phase is set. The corpus luteum can only live for a certain amount of time before it dies unless you get pregnant. So if you have a regular but long cycle, you ovulate later in the cycle than somebody who has a shorter cycle. So we usually say the luteal phase is set between 12 to 14 days. We will use 14 for this example. If you have a 24-day cycle, you are going to be ovulating around day 10 to have your 14-day luteal phase. If you have a 34-day cycle, you are now ovulating around day 20 to have your 14-day luteal phase. If you have a 44-day cycle, you are now ovulating around day 30 to have your 14-day luteal phase. So you are ovulating. The detection of your ovulation seems 1000% accurate in context of your luteal phase and the length of your cycle. However, is it normal? No. Having cycles that long can represent a few different issues of hormonal imbalance, for lack of a better word. Most commonly is going to be PCOS. So in PCOS, my bad way to describe it is that if you're born with too many eggs inside your vault, your body's going to compensate by sending out a higher number every single month. So great, that doesn't sound like a problem. You have more eggs. But what happens is that the brain does not know you have more eggs, and it sends out its regular amount of FSH. And this regular amount of FSH is getting diluted amongst all of the follicles. So if you have 40 eggs available that month instead of 20, each of your follicles is getting half as much of a signal. And that's just not enough to get it to grow in that regular, predictable pattern we want to see. So maybe it takes longer. A follicle has to see a longer duration of FSH since it's not strong enough, and seeing this delayed ovulation, what feels like a very long follicular phase, can be very classic in patients with PCOS who are still ovulating. I view ovulatory dysfunction as a spectrum, perfectly regular cycles. And then one step up from that is going to be a short luteal phase, closer together cycles. And then a step from that is going to be having a longer follicular phase, what we're having now. One step up, irregularity, don't know when it's happening. And one step up, no cycle at all, amenorrhea. PCOS can present in any of these as it is a dynamic disease. It's going to differ based on your weight, your stress, your nutrition, your age, some of the factors you control and some you do not. So you might say, well, my periods used to never be present, but now I have this. That still can be PCOS. But it also can be thyroid disease. It also can be prolactin abnormalities. It also can be stress or issues with your hypothalamus. And this is something where we say the normal range of a period, the high end that we tend to like to see, are cycles every 35 days apart. Because otherwise it can be indicating a problem or a dysfunction that is cluing us into something else happening inside your body. In this case, it does appear that you're ovulating, but is your ovulation normal? I would say no. This follicular phase is too long. Not only is it not giving you as many opportunities to get pregnant, which of course is a problem, it also could represent an endocrine or a hormonal issue underlying that we want to get to the bottom of. So please go see a doctor so you can get some testing done. All right, and so our very last question we're going to get to now, but a reminder, the voicemail, 657-229-3672.
Hi, Dr. Crawford. I have been trying to conceive for about 10 or 11 months. I'm 33, and I've been seeing a fertility specialist. Everything is good on my end and on my husband's. I also had an MRI with contrast to check for endometriosis, as well as an HST test, and everything is good. They recently just prescribed me Letrozole and said that I can do timed intercourse with that, and they'll be monitoring me, or I could do an IUI this cycle with it. It's really up to me. What would you recommend? And if there's anything else you can recommend, it would be greatly appreciated. Thank you so much for taking my question. Bye.
I'm so sorry that you are having infertility, and let's dive in. Unexplained infertility is when you don't have one of the top causes of infertility. I always like to say it's undiagnosed, which feels very unfulfilling, and I know this because I've been there. But that means normal HSG test, so your fallopian tubes are open, inside of the uterus is normal, you ovulate, sperm is fine. In those cases, you now get the magical diagnosis of unexplained infertility. The two big ideas for treatment are either I need to improve the odds of egg and sperm coming together, or I need to override as much as possible and make egg and sperm come together. So improving the odds is going to be a combination of ovulation induction with the goal to get more than one egg, so 2 or 3 eggs is ideal, and an IUI, the combination. So you want to take Letrozole or take Clomid, have monitoring, and then you're going to want to do an IUI at that time frame. Studies do not show a benefit to ovulation induction with timed intercourse in unexplained infertility. So unless I'm missing a piece of the puzzle and we think there's some ovulatory dysfunction or issue where Letrozole would help that, then I would strongly recommend for my patients, Letrozole timed intercourse doesn't have a purpose in unexplained infertility. So if everything's normal, if we do ovulate, then the answer here is IUI. Now, even with that, ovulation induction plus an IUI, your odds of going to get pregnant are about less than 10% per month, which feels real sucky. Remember that we're bound by the top of our age-related norm. At age 33, that would be a little under 20% per cycle. Once you get to 1 year of trying with unexplained infertility, now you have a 4 to 5% chance per month. And at 2 years of trying with unexplained infertility, it's 2 to 3% per month. So doing ovulation induction plus IUI and getting an 8% chance per month is statistically better. However, it still means the most probable thing is that it's not going to happen, and you need to have a game plan. What are we looking for? How many cycles are we doing? IVF is the only thing that's going to ever exceed your age-related chances of getting pregnant, and it covers so many things that could go on for unexplained. So we're overcoming fertilization issues, we're overcoming potential ovulatory issues, overcoming tubal factor, overcoming genetics if we do genetic testing, suppressing endometriosis if we use Lupron. So it is just a much stronger tool in our tool belt. Does that mean you have to do it or you won't get pregnant without it? Absolutely not. 2 to 3% may sound very low, and in fact it is, but it's also not zero. And for any one given person, no matter what the chances, for you yourself, it's 100 or nothing. You either get pregnant or you don't. It's important for you to understand statistics so that you can make a good decision for yourself. But for this one, the data is clear. Would not spend your money or time with Letrozole and timed intercourse if you're having ovulatory cycles. If you're not ready for fertility treatments like IUI or IVF, just have sex with your regular ovulation because your odds are essentially the same as with Letrozole and timed intercourse. All right, guys, these were fabulous questions, and I hope you found some answers helpful. I do love answering your questions, so please keep calling and asking them. You can call and leave a voicemail at 657-229-3672. Again, that is 657-229-3672. You also can ask a question on Instagram on Monday at nataliecrawfordmd and follow along the newsletter, nataliecrawfordmd.com/newsletter. Don't forget to check out the YouTube channel where we have short 10-minute videos answering all of your top fertility questions. Thank you, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd and check out the YouTube channel nataliecrawfordmd. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.